Okay, excellent. Thank you. So yeah, it's thank you for asking me to talk. I wish I could be there in person, but we'll have fun over Zoom. So as Kate said, I'm a skull-based surgeon, and that a vast majority of our work is acoustic neuromas. So I'm going to talk about hearing preservation in acoustic neuromas, and then I'll talk about one of my other topics that I'm an expert in is complications. So acoustic neuromas, hearing is one of the major symptoms and patient factors, obviously, that we're dealing with these tumors. Most tumors are actually vestibular schwannomas, but they obviously run very closely with the acoustic nerve and commonly cause hearing loss. So that's one of the most common presentations in acoustic neuromas is progressive unilateral hearing loss. But tinnitus and dizziness, buzzing in the ear is also very common as well. Sometimes frank vertigo. So for acoustic neuromas, treatment options are obviously observation, surgery, or these days stereotactic radiosurgery, usually with gamma knife, plays a big role. At our institution here in Melbourne, we've just got a gamma knife about 3 years ago, and it's been going really well. So hearing, a lot of the classification and studies on hearing were developed back in the 1950s and 60s by originally Gardner and Robertson, and then at the House Institute in LA. So in 1995, the American Otolaryngology Society came up with the hearing classification system that's still used today. So there's class A, B, C, and D, and it's based on pure tone threshold levels, as you can see there, and also speech discrimination. So the term serviceable hearing is often used to refer to a person who's got pretty good hearing still that's usable, with pure tone above 50 decibels and speech discrimination above 50%. A common question that we ask patients is, can you talk on your mobile phone on that ear still or not? And usually the patients with a significant hearing loss can't. They have to use the other ear for their mobile phone. So here's a case, 62-year-old presented with 10 years of progressive hearing loss and more recently falls and dizziness. They originally had a CT scan back in 2019. You can see there was a small tumor there that was actually missed by the radiologist. And then 3 years later, they came to have an MRI showing a much larger tumor. So if you have a patient like this with a clearly growing tumor, increasing deafness and symptoms, then surgery is usually the recommended course of action. So we have 3 surgical options. So what's the relationship of these options to hearing preservation? And this is a rough guide to what we do here at Royal Melbourne Hospital. About half of our cases are retrosigmoid approach, half a translab approach, and a very few middle fossa approach. So the middle fossa approach is a fairly specialized approach for small tumors where the patient usually has pretty well preserved hearing, and we can remove the tumor out from the canal and usually preserve hearing in most cases. The stats are about 85%. For the translab approach, that's really the workhorse for large tumors and for people that have already lost hearing or have almost already lost hearing. So with the translab approach, you come through the vestibular apparatus, and obviously there's no chance of saving hearing with that procedure. So we need to talk to the patients about that. But most cases who have that have already lost hearing. The retrosigmoid approach is really very variable. That can be used for small or large tumors. And the rate of hearing preservation depends very much on whether we can save the acoustic nerve and how stretched it is over the tumor. So we really often can't decide until we look in with the surgery to see what the situation is. But the rate of hearing preservation is not that great, even for small tumors, probably 50% or less. The story for facial nerve preservation is much, much better than for hearing. So these days we can get usually better than 90% or even 95% saving of the facial nerve with almost all approaches with modern microsurgical techniques and neuromonitoring. So here's a case, a 39-year-old sales manager with 6 months of progressive left tinnitus and very mild hearing loss. So you can see that on the left side there, He's just got a little bit of high-frequency hearing loss, and his MRI revealed a small tumor, completely intracanalicular, just 4 or 5 millimeters in size. So what do we do in this case? In this case, we decided to monitor. Often we recommend observation in the first instance. So we monitored him for a couple of years, but he was very keen to try and get rid of the tinnitus, which was really bothering him. So with some reluctance, we recommended a middle fossa approach after discussion of the other options, such as SRS. And he went on to have a middle fossa resection. And the small tumor was successfully completely resected. The seventh nerve at the time was intact and stimulating very well. But post-operatively, he didn't have a great outcome. He had no hearing and a moderate facial weakness. Now, at 2 years, he's now at 2 years. I saw him recently. He still has no hearing. He's still bothered by tinnitus, but his facial nerve palsy has recovered. So that's a disappointing result, just to show that the difficulty of actually preserving hearing in many cases. And the tinnitus is really very, very difficult, and there's no really well-recognized treatment for it. So he's actually now having consideration of either a cochlear implant. And the other thing you can do for people who've lost unilateral hearing is a cross hearing aid, which takes the sound from the good side and puts it over, sound from the bad side, puts it over to the good side. So that's surgery, which is sometimes good with small tumors, but not always. What about hearing preservation with doing nothing, with just observation? Well, that's not that great either. There was a large retrospective meta-analysis published last year of 3,500 patients over 26 studies. And these were the results. The serviceable hearing rate went down to 75% after about 3 years, 60% at 5 years, and 40% at 10 years. So even if we're just watching the tumours and the tumours are growing, the patient will gradually lose their hearing over the years. So observation does not avoid hearing loss either. This has been repeated in a number of studies. Now, a lot of these observation studies, remember that these were cases that were deemed safe to watch. The larger cases or the more symptomatic cases are usually operated on. So there's a slight selection bias there. But other studies like this one recently from New York was a retrospective review of 128 patients. And again, they showed very similar stats in terms of the loss of hearing, with 60% people retaining hearing at 5 years. Is the hearing loss related to the size of the tumor? The answer seems to be yes, not directly, but the graph here you can see down the bottom shows that the tumor size in red and the loss of serviceable hearing here, basically following the size of the tumor. Now, we certainly do see people who present with small tumors that have no hearing, and sometimes large tumors that still have very good hearing, and they present a clinical dilemma quite often. But the general trend is that the larger the tumor, the more likely you are to lose hearing. Now, the other well-known treatment modality these days is, as I mentioned, gamma knife radiation. This has increased massively it's been around for 30 or 40 years now. So here's the number of cases treated worldwide since 1991. And the results of gamma knife surgery in terms of tumor control are very, very good and getting better. So the studies now show better than usually 95% control for 15 years plus, and probably there is a longer effect as well. So it's very good for small tumors. It's not used for large tumors. Usually they're symptomatic and require surgery, but certainly the gamma knife is ideal for smaller tumors, particularly in older or unwell patients that have a higher risk for surgery. So is SRS good at preserving hearing? Well, the answer is probably not that good either. Here's another large registry study of gamma knife, 175 patients with 3-year follow-up. Now, note that when we originally treated acoustic neuromas with gamma knife, the whole area was given the same dose, but the modern treatment paradigms limit the dose to the cochlea, because that's obviously where we want to preserve hearing. So less than 4 gray is now given to the cochlea, often around 3 to 3.2 gray as well. So this paper showed that the time to serviceable hearing loss is around 2 to 3 years, 38 months, with 77% hearing preservation after 1 year and 62% after 2 years. So again, it's very similar to the rates with just observation. Now, whether that's from the tumor changing or growing, or whether it's from direct damage from the radiation itself, we're not entirely sure. Certainly the tumor can sometimes enlarge for a year or two after SRS, that we see that, before it shrinks and becomes more necrotic. That usually takes about 2 to 3 years. So is the patient going to retain hearing? Usually younger patients retain hearing better than older patients. Their nerve is probably more healthy. This particular paper talked about the free canal space. So whether there's CSF or space around the nerve leads to a better hearing outcome as well. And better preoperative hearing usually leads to better postoperative hearing as well in all modalities. Now, NF2, I've got the last couple of slides regarding NF2, which is a difficult and a whole separate dilemma when we're talking about acoustic neuromas. These patients have bilateral acoustic neuromas. They're often more aggressive. They often grow faster. Patients are younger, and eventually NF2 patients will go deaf. They'll lose hearing completely. But the aim of treatment over the years is to try and preserve the hearing as long as possible. So usually they end up having one side treated with surgery early on, and then their hearing depends on the other side. This patient here I'm showing in the picture had surgery 4 years ago to remove or debulk the left-sided tumor through a translab approach, and that tumor has now grown back substantially. He was deaf on the left side because of the translab approach, and he had some hearing on the right side, but now that tumor is growing to a marked size, and you can see that the severe squashing of the brainstem between the two tumors. So he's probably going to need surgery now to debulk that right side tumor, and there's no chance of really saving any hearing there. So the principles with NF2 are you often can't aim for a complete resection, and it's better to go for a debulking or a subtotal resection, and that gives you a better chance of saving both the facial nerve and some hearing function. But it's very difficult. Eventually they lose hearing function and sometimes facial nerve as well. So other options for small tumors in NF2, again, gamma knife radiosurgery. Avastin has become an option in recent years, and auditory brainstem implants, which is something that we've been doing for many years, 20 years plus. And they can sometimes restore a little bit of hearing, but they're nowhere near as great as a cochlear implant. So here's a 20-year-old girl was diagnosed with NF2 at age 15. The right side acoustic neuroma was removed when she was a teenager, and now the left side is growing substantially, as you can see. She did have some hearing on the left side and now nothing. Now this tumor is quite large, so she's been developing headaches, coordination problems, and walking difficulty and balance problems. So it's not really a candidate for stereotactic radiosurgery. So she went on to have surgery to remove that, again via a translab approach, and placing an auditory brainstem implant. You can see the implant has a wire that shows up on the CAT scan there. It's placed through the foramen of Luschka into near the cochlear nucleus. And hopefully it's going to give a little bit of sound. But sometimes they get enough to get a little bit of speech discrimination, but as I say, it's not that great. So the last slide is on Avastin, which is an interesting one that's come up in the last few years. So the first report was in the New England Journal in 2009 in patients with NF2. They treated with Avastin, and interestingly, there was quite a marked improvement in volume. So most of the patients had a volume reduction, and about half the patients had hearing improvement. Now, the question with Avastin is how long can you treat them for, and how long is that effect going to last? There's a more recent paper here that showed very similar results in a more modern paper. So 60% hearing improvement, 30% stable, and 10% worse. So we certainly have been considering Avastin in Australia. It's recently been approved on the PBS for 6 months use. But the data really only goes out to about 2 years at the moment, 2 to 3 years. So we really don't know whether it's able to be used in patients with spontaneous non-NF2 acoustic neuromas who probably need treatment for 10 or 20 years sometimes. And we still are waiting for more data on that. So in summary, most patients with acoustic neuroma end up losing most of their hearing, unfortunately. But otherwise, it's a benign tumor. The recurrence rate is very small. The surgery is generally very safe. So they all do pretty well, but the hearing is the one thing that's very difficult to save, whatever way you treat it with. If surgery is necessary, sometimes we can preserve the hearing with small tumors using a retrosigmoid or a middle fossa approach. But again, there's also a risk of the surgery causing so-called sudden hearing loss if we need to damage the nerve. Observational radiosurgery can potentially preserve patients' hearing for longer, but still probably only a few years. The stats show that, as I mentioned, only 60% have serviceable hearing after 5 years. And then NF2, certainly much worse outcomes. They all lose hearing. And the idea is to try and preserve it for as long as possible with debulking surgery, radiosurgery if possible, and now Avastin, as I mentioned, which is available in Australia. I'm not sure what the situation is overseas at the moment. It tends to be a very expensive drug, and only some patients can afford to have it prescribed. Thank you very much. That's the end.